The video
Hi, good
quality
evening, sir.
was a little jerky. It was not
Okay.
flawless like your talk and everything else. But we enjoyed the video. It was very nice. I just wanted to ask you, why do you choose this method of anastomosis? It looks a little clumsy, creating another opening and then putting in a circular stapler. Why not just hand-sewn when you are doing a robotic?
Yes, I know, but generally speaking, for a proximal, I have really never used a hand-sewn method. A proximal in open, I have always done a stapled anastomosis, to be fair. In a total gastrectomy, I have used a hand-sewn, and actually that is my preferred go-to technique. But it's just something which I was used to do, and I did it because I just wanted to use it. But I have used it multiple times in proximal gastrectomy, and it's not very clumsy. Ultimately, you have to remove your specimen. So just removing the specimen and putting a stapler looks a little odd. But in a patient who has a decent BMI of around 25 or less, you can comfortably do this anastomosis. In high BMI patients, sometimes it can be a problem because then your incision needs to be longer and the distance for the conduit to travel becomes difficult. But in a patients with up to 25 BMI, I think this is quite okay. Quite okay.
Can you prevent the air leak while the stapler goes in? You use how do you prevent the air leak?
So what I did was, if you saw this technique I picked up from Koreans, what they do is they tie the glove to the center of the to the shaft of the stapler, and you tie the glove to the shaft of the stapler. Then you put the stapler into the gastrotomy, take out your spike from the gastrotomy, put this whole assembly inside, and then fix the glove to the Alexis port. So it's not very difficult. It's a very straightforward thing. Only thing is that you have to know it and you have to do it sometimes to just streamline it and standardize it. But it's a good technique to do that.
Enjoyed it. Thanks.
Yes.
Hi Vikram, I'm Dr. Pratap
Hi.
Reddy from Baswatarakam.
Hi. Good evening, sir.
You literally did a proximal gastrectomy for, in the end, a benign
Yes.
condition. Are you not worried
I-
about bile reflux?
Yes, I
and
know.
the
So
second,
even for an early gastric cancer, I completely take your point. And in fact, in lot of early gastric cancers where I'm doing a proximal gastrectomy by open technique, I'm indeed doing a interposition of a jejunal limb in lot of patients, not all, but lot of patients. In some old age patients, I have skipped it, but in most patients who are younger or patients who are doing requiring a proximal gastrectomy for a diagnosis like a GIST or a diagnosis like a neuroendocrine tumor, I have more often than not done a interposition. This particular case, I have not done it, but to be fair to me, the diagnosis was cancer, and finally it turned out to be a neuroendocrine node positive. So though my surgery is justified, yes, I take your point. An interposition could have been considered in this patient.
the
Or
second,
anything else you wanted to suggest?
yeah, second question is, in adenocarcinoma, generally you avoid proximal gastrectomy as most of the time in locally advanced. Do you do,
So
do you
hmm.
do for locally advanced CS stomach proximal gastrectomy?
So if you ask our experience, even in locally advanced gastric cancer where the nodal burden is not significant on radiological evaluation and even during intraoperative evaluation, even up to T4A proximal tumors, we have seen that the results of proximal gastrectomy and total gastrectomy are same. The PFS, DFS and survival with this are same, and we have published in Annals of Surgical Oncology. So if you ask me our own experience, it's a comparison of around 250 proximals and 250 totals, and we have seen that the survival in the proximal gastrectomy is not inferior to total gastrectomy. So that debate for our own patients is settled for us. So even for locally advanced, if the disease burden at station 6 and 5 is not significant, and if I think I can achieve a R0 resection, we still go ahead with proximal gastrectomy in a lot of patients.
In those cases where you have done proximal gastrectomy for locally advanced proximal stomach cancer, what was the positivity of station 5 and 6 nodal disease?
So if you ask me, we do not clear the station 6 in these patients. You can definitely clear the station 6 by still preserving the right gastric artery. You have to be a little careful in that area. While taking the station 8, you can also clear the station 5. But you have to take care that you preserve the right right gastric vein and right gastric artery. But if you ask me a specific station 5 positivity, I will not be able to quote. But we do make a point to take out the station 5 even in proximal gastrectomy patients.